was a great pleasure again to listen to Dr. Furlan from Pittsburgh. He talked about LR-TIV, and he covered the significance and a correlation and importance of bland thrombus and tumor thrombus, and that was really very informative. We have few questions here, Dr. Furlan. So the first question is from Dr. Singh, Somesh Singh. Dr. Singh, can you please speak your question?
Hello.
Hi, Dr. Singh. Where are you from?
I'm from India.
From where?
India.
India. You are very welcome, man, to join. We're very happy that you're here. So you can speak your question, please. Go ahead.
Suppose we have an observation which is about 3 centimeter in size. It shows arterial phase hyperenhancement, shows washout, and also has a enhancing capsule on the delayed phases. But it also shows a tumor in vein, which is definitely tumor in vein. So would this observation be categorized as an LR5 or as an LR-TIV in the final impression of the report?
Yeah, thank you very much for the question. So again, that's a very good question, and that allows to clarify the position of the LI-RADS TIV in the algorithm. So LI-RADS TIV belongs to the very first portion of the algorithm, to the diagnostic tree, which is the first section that you meet in a way that you use when you apply LI-RADS. So which comes way before the diagnostic table. Let me pull up the slide one more time. It's just here, and then I go back to my picture. So it's up here. So it's a category that you have to exclude before assigning 3, 4, and 5. So the situation that you described, meaning you have a clear-cut hepatocellular carcinoma in the liver that you are looking at, but you also have a clear-cut diagnosis of tumor in vein, that what LI-RADS would suggest is that you classify it as TIV, but then also say that it's next to a LI-RADS 5 observation, and it's definitely due to hepatocellular carcinoma. And again, the reason why this TIV is up here is to keep the specific, one of the reasons it's up here is to keep the specificity of LI-RADS 5 as high as possible. I hope this answers your question.
Yeah, thank you.
That was a great question and a great answer. Thank you very much, both. And actually, the second question is the same question. So great minds think alike. It's from Dr. Abdullah Muhammad. Abdullah, you can speak if you want. You can mention if I don't understand your question correctly, but if I understand it correctly, it's the same question of Dr. Singh. Is that correct? Abdullah?
Maybe it was the same question. Yeah.
It was the same question. It was the same question. So we have another question, and it's from my shy friend from Alexandria, Egypt. His name is Muhammad Eid. I in purpose mentioned his name because he's shy. So he's saying, what's the Hounsfield threshold that qualifies as unequivocal enhancement? Is it 15 Hounsfield units, 20 Hounsfield units? Question mark.
This is another great question. Thank you. To my knowledge, there is not a threshold and there is no recommendation in measuring it either. As you know, the evaluation of arterial phase hyperenhancement in LI-RADS is a qualitative feature, and that is true also for the assessment of enhancement in a portal vein thrombus. So it's a qualitative, mainly a qualitative assessment. So I'm not aware of a recommended quantitative Hounsfield unit threshold. The enhancement does not necessarily have to be on the arterial phase, right? You can assess arterial and portal venous phase for that enhancement. If you have an MRI and if you have doubts about the enhancement, that in that situation, I think it would be helpful to get a subtraction images unless they are very artifacted. But for CT, I'm not aware of a recommended threshold. Khaled, are you?
Yes, but I still don't see your picture.
Oh, okay. Let me put it back. So
another great question from Dr. Diego Hepperman. Dr. Diego Hepperman, can you please say your question? Okay, I'm going to just read that for you. How do you categorize a thrombus that you are almost sure is a bland thrombus, even with LR5 liver observation? And how your multidisciplinary team manage these patients? Drop out from transplantation wait list or give a chance? Question mark.
yeah, very good question as well.
Give a chance. Give that chance. He continued his question in another comment. Give the chance for surveillance and see if it's in close control. That's what he wanted to say.
Excuse me.
Hello?
Yes.
Yeah, so that's a very good question.
Here I'm Diego Haberman. Good morning.
Hi, good morning.
Oh,
Thank
good
you for the
morning,
question.
Diego. Yeah,
No,
yeah, go ahead.
In Argentina, we don't.
Ah, from Argentina.
No, excuse me. I would like to comment that. Yes, from Argentina. Here in Argentina, we don't have available contrast and enhanced ultrasound, and sometimes biopsy it's not available too. So perhaps I'm afraid this patient drops out from waiting list, even when I'm pretty sure this is a blunt thrombus. So I'd like to know, how do you manage and how do you report with categorization LI-RADS? No?
Yeah, well, thank you for the question. I think the answer may, it's not an easy answer, I believe. It may depend a lot on a case-by-case situation and on how what are the chances for that patient to get a liver transplant, regardless of the presence of a thrombus in the portal vein. The way we manage, in our institution, the way we manage unclear cases of tumor in vein, if the patient indeed has high chances of getting a liver transplant, then we really need to know, but the images are not that clear, then it's either with a biopsy or with contrast enhanced ultrasound. If you don't have those two options available, and the patient is on a transplant list, and if the patient is receiving some sort of bridge therapy, like local regional bridge therapy, it may definitely make sense to reevaluate, re-image after the local regional treatment to assess the changes in the vein. But again, I think it would be probably a case-by-case scenario and solution.
Okay, great.
Thank you very much.
Thank you, doctor.
Yeah, of course.
Thank you. Thank you very much, Dr. Diego Heberman from Argentina. Say hi to Messi. Okay.
Of course. It's a close friend of mine.
So we have Dr. Gabri here. Dr. Gabri, do you want to say your question? Do you want to speak your question?
Hello, Dr. Furlan. Thank you for this great talk. And my name is Ahmed Gabri, and I'm from the Chicago group working on liver-directed therapy imaging of HCC post-liver directed therapy. And I was actually wondering how would you interpret viable versus non-viable tumor thrombus in patients undergoing liver-directed therapy, such as Y90 or SBRT? And sometimes it's even patients who are on sorafenib exhibit some sort of regression in their PVT, and we show this we can see this in the very small number of patients who get occasionally transplanted. So while working on this, it doesn't really seem that we have some sort of specific criteria, but I'd like to hear your opinion about that.
Thank you. Thank you very much for joining our lecture, and thank you for your question. So a couple of things. One is very good question, and as Khaled mentioned, I mean, let me put up this slide. There are going to be actually 2 talks coming up next week on interpretation of treatment response, hepatocellular carcinoma response, one by Michon and one by Richard. So on the April 28th and 29th, I'm sure they're going to go in depth into this analysis. Now, what I would say is that we are looking at again the same features, meaning like we're looking at the enhancement of the enhancement of the thrombus and as the main features leading to the diagnosis of residual viable tumor after local regional treatment. The way as you know very well, I mean, the way that the tumor and perhaps in part the tumor in vein as well may appear after treatment may not be the same depending on the treatment, and definitely if you have some Y90 treatment, the morphologic changes and the heterogeneous enhancement changes that occurs in the area of treatment, especially in the first phases after treatment, may be different than on TACE or radiofrequency ablation. So it may be difficult to just find an answer here to your question that can cover all treatment, but if I have to find one, if I have to select one, I would still look for the enhancement in the presence of soft tissue enhancement in the vein as residual viable tumor in the site. Would that reflect your experience in Chicago?
It's kind of, it's just, it differs from patient to patient. Sometimes the PVT is already not enhancing at baseline, but there is some sort of change in tumor in the size or regression of the actual tumor mass around it. So it's pretty much there is no solid definition for this, and this is why I will probably have to ask this question to different people just to get different opinions. And so far I can't find any specific criteria. The thing is that it even what it feels like, it depends on the extent of the thrombus. Even sometimes if it's lobar or a segmental involvement, things become different. So for segmental PVT, we see that sometimes they just resolve, like we don't see them at all. And in lobar, it's just sometimes I feel like there is some sort of disappearance of enhancement. And in some other few patients, we will have to depend on the diffusion weighted imaging. So it's kind of confusing, but yeah, that, just as you mentioned, if we have to pick one, I think I agree with you about the enhancing.
Yeah, no, definitely a difficult scenario to evaluate. Thank you very much for bringing this up. And again, if I can remind you or anybody else in the call, particularly interesting in this, and Khaled, correct me if I'm wrong here, but next week again, Michelle and Richard will be spending their lectures on again assessment of post-treatment, and they may have data that I ignore, and they may contribute to this conversation.
Thank you so much. Thank you. That was really helpful. Thank you.
So we have last 3 questions, Dr. Furlan. I know that you have to go. So from Richa, can you do you want to give the question? Richa? Am I pronouncing it correctly? Yes, Richa, where are you from?
Hi. Hi,
Where are
I'm
you
from
from?
Bangalore, India.
Oh, great, great. Nice having you.
Hello.
We're happy you're here. Go ahead.
Thank you. It was a great lecture. Thanks a lot. I had a very quick question. In case if you have the involvement of the hepatic veins, you still call it as a TIV or tumor in vein?
Thank you for the question. Yes, yes. Indeed,
Okay.
it's more common for portal veins to be involved than hepatic veins, but especially hepatocellular carcinoma can definitely invade branches of the hepatic veins. We see that happening more commonly when the tumor is located towards the hepatic dome. And you use the same set of criteria that I described in the lecture. It's just more common to happen in the portal vein, but it can definitely happen in the hepatic veins as well. Yeah.
Okay.
Thank you.
Thank you.
Thank you, Richa. Thank you, Dr. Furlan. Another question, Dua. Dua, can you please give the question? She may be too shy. I'm gonna have to. Yeah, Dua, go ahead. Oh, maybe it's tempting for her, but okay, she's hesitant to speak. So is the blend thrombus similar in imaging to the necrotic hypoenhancing tumor thrombus? That's a Dua question.
That's a very good question. Like, in other words, if I can rephrase it, can a necrotic tumor thrombus mimic a blend thrombus?
Yes.
And I would say yes to that. Indeed, if you have no enhancement in a tumor thrombus because the tumor is mainly necrotic, then yes, it can definitely mimic a blend thrombus, especially if you have only one time shot, right? One study at one time, and you don't see the evolution over time. So it can definitely mimic, yes. Yeah.
I think also that Dr. Eid actually is asking another question, but it was similar to your answer here. So thank you very much all. I wanted to say buongiorno. Actually, Roberto Canella from Italy is with us. I don't know whether you are aware of that or not, but he's saying big hi to you. He's telling me buongiorno to me, but he's saying big hi to you. I mean,
Yeah.
is this a discrimination or favoritism? Maybe favoritism.
No,
Thank you.
Dr. Canella is a friend, an amazing liver imager that I had the honor of having as a guest in our department for more than a year, and is a rising star that helped our group tremendously, and will have a bright future in our society.
Thank you very much. I mean, thank you very much, Dr. Canella. It's an honor and a pleasure to have you here. And also Dr. Federica Vernuscio from Italy also is telling you buongiorno.
The same thing I said for Roberto is true for Federica. The only difference is that Federica did not spend some time in Pittsburgh, but she decided to go to Duke in Durham.
So you know already, you guys know each other. Okay, that's great.
It's an Italian liver connection.
Oh, that's perfect. And Dr. Juan Manuel Perez is thanking me actually for the course and thanking you for the great lecture, and he's sending his greetings from Bogota, Colombia. And it's sorry about that, but it's very funny that when you meet people from. I asked him about Jorge Soto. So basically, Jorge Soto is from a different city in Colombia, which is rivals with Bogota. So they don't actually, like acknowledge each other. So thank you very much, Dr. Perez, for coming to the lecture. And do you have just 1 minute, Dr. Furlan, for a last question?
Of course.
From Taron. Taron is asking, Taron, are you here? Do you want to give the question?
Yes. Yeah. My question is the
Taron, where are you from? India?
I'm from Little Rock, Arkansas, in University of
Oh, great.
Arkansas.
Oh, great.
Yes.
Nice having you. Nice having. Go ahead.
Yeah. So my question is, many times the infiltrative HCCs don't enhance that much, and if you have a tumor in the thrombus in the portal vein or any vein, how do you kind of deal with that situation? Because if the native tumor is not enhancing, the thrombus is also not enhancing. How do we be more definitive about whether it's a tumor thrombus or a bland thrombus?
Yeah, no, that's a very, very good question, and unfortunately, is a situation that we face not infrequently. You know, in those situations, I guess you can suggest the presence of tumor in vein without being definitive. Unfortunately, those patients may not have a shot at liver transplant just because of the infiltrated nature and extension of the tumor to start with. But again, if you don't strongly recognize that enhancement in the vein, I guess you can suggest it without being definitive. You know, in those cases, it's also challenging to categorize that diffuse and infiltrative type HCC. I know that Claude touched base on this on Monday, but it's you know, if you clearly see the enhancement and washout, then you would use the LI-RADS 5 category. But if you don't, those would be like actually categorized as LI-RADS M. Challenging situation, but again, to preserve the high specificity of the LI-RADS TIV category, if you don't see the enhancement, but you see the continuity, the expansion of the vessel, the restricted diffusion, you're going to suggest the diagnosis without being definitive.
Great, great, great.
Thanks.
Thank you very much. Thank you very much, everyone. Appreciated, Dr. Furlan. It was such a pleasure again to see you around. It's always a pleasure to see you, just without even speaking. But when you speak, it just adds to the pleasure. And this was very informative. So we all appreciate that. And thank you very much, everyone. So again, at the same time, we have an exciting lecture with Dr. Jimmy Lee from University of Kentucky. Actually, tomorrow lecture is really very dense, and although it's an optional to use ancillary features, it is very, very useful to learn, because even if you don't apply LI-RADS, which we really strongly recommend to apply LI-RADS, it just to give you fund of knowledge of the characteristics of HCC, malignant and benign lesions, which will help really fund your knowledge even when you teach residents, when you actually write your report, it increase your confidence. So we'll actually be there tomorrow again in the same time with Dr. Jimmy Lee. Without further ado, thank you very much for your time, Dr. Furlan, and thanks everyone for coming from all over the world to attend. See you again tomorrow. Appreciate it.
Thank you.
Thank you.
Dr.
Thank you, Khaled. Thank you, Khaled, for your leadership. Thank you.
Appreciate it.